with Bhekisisa. We often think of climate change as being about extreme weather, those heat waves, droughts, and floods. But it's also about superbugs. Those are infections that no longer respond to the medicines that are meant to treat them. As the planet warms, floods spread waste and germs through water and soil, and heat helps those drug-resistant bugs or bacteria to survive for much longer. At the same time, health systems are stretched, and it means that that itself gives resistance more chance to grow. But the story is not often told. This week, WHO released a report called the GLASS Report, the Global Antimicrobial Resistance Surveillance System Report. And I've seen stories about it in The Guardian, in a few UK and other international publications, but so far I haven't seen anything in local media. I hope that will change. But of course, the GLASS report is incredibly comprehensive and complicated and has, a lot of jargon in it. So, that's exactly why we're doing this discussion today, because we have two scientists who know a lot about superbugs, and they're going to tell us about two aspects of the story that are not often told in the media. I'm very excited to welcome them to talk to us, but just a little bit about sort of housekeeping and how this will flow. It will be an hour-long discussion. There will be good time, proper time, ample time for questions and answers afterwards from journalists on the line. And also one other housekeeping thing I'd like to ask you to do, everybody on the line, is to keep yourselves on mute. We did receive a lot of questions in the pre-registration. I'll read out some of those questions. There will also be an opportunity to ask spontaneous questions that may come up for you. Do also place any additional questions in the chat box, and our team will look out for them. Thanks very much to our supporters, the Wellcome Trust, for making this webinar possible, and indeed our series of working with scientists and journalists together to tell the story of how climate affects our health. Dr. Luther King, I'm going to come to you first. He is with the College of Health Sciences at the University of KwaZulu-Natal and a real antimicrobial resistance specialist. King, you know that we journalists like to say superbugs instead. So just before we ask you to talk about your area of expertise, is it okay to say superbugs? Or is it like those journalistic phrases like frankenfoods or frankenscience? I mean, how do you as a superbug specialist feel about that phrase?
Yeah, I just feel okay about it because that is what it is for real. If you were to place it in terms of a human being, you take somebody like me that is very small and you take a very big muscle builder and you put both of us together. That is just what happens. The bacteria have learned to build themselves because of the pressure, and they're superbugs. Yeah, they are doing unimaginable things, believe me.
King, you say they're all around us, Dr. King. So please go ahead and tell us how that can be. Thank you.
Okay. I hope you don't mind me sharing my slides.
Please do.
Just a minute here.
While King is getting the slides ready, I wanted to tell you that this discussion is part of a Bhekisisa Climate and Health series, as I said, supported by the Wellcome Trust. We have a number of scientists on the line who are also part of that series. So we'll hear from them, from all of them over time. But today is the chance of Dr. King and of Esmita Charani. Thank you so much.
Okay. Can you see my slides, please?
I can.
Oh, yeah. Technology has its own way of doing things. Now I'm going on slides mode, on presentation mode, and my screen disappears. Let me just try to figure this out. I'm not sure why, but okay. Sorry about that.
No problem. In the meantime, we do have a copy of it. So if it's a struggle, Dr. King, we can also share it from our side.
Just be one last hint. I'm not sure why, but because I think this thing just go straight on presentation mode.
King, are you working from two screens?
No, I'm working from a single screen.
It looks like it's wanting to happen.
Yeah, the slide is there. I just needed to go on presentation mode, and when I do that, that is when it participants can now see your, okay, they can now see your presentation, but on my side it's gone.
Oh, I think Dr. King, it's sorry, this is Nicole from Bhekisisa. I think
Yes.
it's because you're on the last slide. I don't know if you can maybe just start it from the beginning, maybe. Because it's the little note that I see says that it's
There we go.
okay.
I'm not the one who went to the last slide. Okay. Sorry about that glitch. I am King. It's easier going that way. I mean, I don't have a crown, but that goes. So hello everybody, and welcome to this talk, this discussion about superbugs. I think I like the journalistic approach of presenting them. So I'm going to be talking about antimicrobial resistance, that is, and saying that superbugs are all around us. As said, I'm at the University of KwaZulu-Natal at the College of Health Science, where I lead the environmental dimension of antimicrobial resistance. So I look for bugs that are resistant and understand how they behave in the environment and how that relates with humans and animals. So if we just look at the eureka of medicine, what I call eureka of medicine is when they discovered antibiotics, it was during the First World War, just towards the end of the First World War, or the Second World War, yeah. And when that happened, a lot of soldiers were not going back home because of wound injuries. But when the antibiotics were discovered, it became easier for people to get back home because they were being treated. It was that wow moment, and it was a great joy for many families because they could get their people back. However, this same eureka led to something else. If we look at antibiotics in history from the creation of the first one right up to the end, then we will realize that sorry, where is my presentation now? No, okay. So we'll realize that by 2017, in fact, immediately the antibiotics were discovered, and by the time they were commercialized by 1942, massive use started. People started using them in human medicine, in animal medicine, and as the use continued, immediately resistance started as well. So you can see that resistance started as early as 1940 already. And by 2017, we just don't have new antibiotics being created. There are few in the market, but what we need to know is that bacteria or bugs, including viruses, fungi, everything, have become resistant to almost every single antimicrobial that we have out there. Now, if we place it then, it says we come from a eureka moment to a pandemic moment. How can something that was eureka suddenly becomes a pandemic? If we look from the 20th century coming up and we look at the greatest killers, we look at we had the Spanish flu, we had the HIV, and then we had the recent COVID-19. Those are the massive ones that took a lot of life. But if we look at antimicrobial resistance, just in 2019 alone, antimicrobial resistance superbugs claimed over 6 million lives. That is in 1 year. That is in 1 year. So if we take the extent of the other pandemics and try to project the number of years to antimicrobial resistance, what do we see if we want to link that to superbugs? It means that based on projections, by between 2025, which is ending, and 2050, we will be recording a total of about 39 million deaths. Okay, I know a lot of people don't like to play with figures, right? But I took that little time just to play a little bit with this figure to see if we are in 2025 and we are talking about 2050, what does that translate to? Now, you probably are aware of the Airbus 380. I think that is the biggest carrying passenger plane that we have now. And depending on which variation you use, but this one, the 380, on a typical mode will carry between 225 to 255 passengers. So what this means is that if we want to say 39 million people will die between 2025 and 2050, we are saying that we will have 8 crashes of Airbus 380 every single day for 25 years. Now, when we look at it that way, then we understand the magnitude of superbugs. And that is why the World Health Organization and many other organizations therefore said, okay, the only way we can address this is if we look at it from a One Health perspective, which calls for communication between humans, animals, the environment, the scientists working in that area, including the media and everybody must, it has to be hand on deck to achieve that. However, when we look at the implementation, animal health, human health, that is perfect. We have a lot of reports going on human health improving. Animal health, we have a lot of reports that are going on. But when we look at the environment, do we have similar reports? I don't think we do. That is backed up by the recent Global Antimicrobial Resistance Surveillance Report, which Ida just mentioned today, that was released just on the 13th of October, right? But if we look at the key indicators in this report, we see that they are talking about 5 things. They are talking about bloodstream infection, gastrointestinal infections, urinary tract infections, urogenital gonorrhea, and they're talking about other things. Every single thing is geared towards human health. So the environmental component is still not there. But when we look at science out there, we have superbugs in the rivers, we have them in soil, we have them in groundwater, we have them in the sea, we have them even in caves, in ice that have been stored for over 13,000 years, that has been dug out from the North Pole. We have them there. We have them in insects, the roaches that we have in our houses, the flies that we have in our houses, they are everywhere. We have them all over the place in our environment. The one environment that I would like to talk about will be the air. Now, when we look at the air, it's something we don't see the air. So it's very easy to talk about superbugs in soil because we see the soil, superbugs in water because we see them. But what about the air? We don't talk about that. And if we talk about air, the atmosphere, which we do not see, and superbugs have been identified in air. There are techniques of sampling air, which is still coming up because a lot of studies have not been conducted, but that show that we have large quantities of these superbugs in the air. They have been found even in the clouds. And if they have been found in the cloud, if we look at this last study down here that talks about antibiotic resistance in filters from air conditioning systems, which means that even driving in our cars, we are not safe. If our air system is not functioning, we can still pick up the air from outside and bring it inside the car. And in fact, wherever we are going, we are surrounded by superbugs. And this even becomes worse with the whole story of the climate change that is going. And in order to place this in perspective, climate change is characterized by 2 main extremes. We have increasing temperatures that leads to drought, and then we also have extreme floods. But when we look at temperatures, what happens with bugs is that the temperature, they have temperatures at which they grow best. And if they are not at that temperature, they will not grow. And it is more and more studies are coming out now to show that as the temperatures are increasing, it allows these bugs to grow faster. And the faster they grow, the faster they can transfer their genetic material from their DNA from one bug to the next. And in so doing, they transfer their resistance potential to the other ones. And that whole mixture therefore leads to an increased rate of superbugs in the environment specifically. And as they increase also, I'm going to take an example that may not be related to superbugs. If we take, for example, malaria. Some years back or many years back, malaria was a story in South Africa, right? But because places are becoming warmer and warmer, it was first of all limited maybe to the Kruger Park. But because places are becoming warmer and warmer, the mosquitoes that transmit malaria have started moving inland into the places where it is warm because it's favorable for them to breed. That is the same thing that is happening with superbugs. Some other bugs like Vibrio, for example, Vibrio that causes cholera, they are used to warm waters. And now the more the waters are warming, the more they are moving inland. So rising temperatures is affecting that gradually. And the study that I just showed also talked about superbugs that were in ice for 1,300 years. And now this ice is melting. The ice is melting. Where is it going to? It is going into the ocean. The ocean is overflowing, coming back into the land. We are releasing bugs that we have not encountered before. So these higher temperatures is releasing bugs that we have not encountered before, that we know nothing about, that have been lost maybe in ancient civilization, and we might not have the tools to fight that. If we look at floods, when this has happened, the flood, what will flood do is floods, once the bugs have multiplied, they are all over the place, floods will just increase, washing them out from wherever they are. We see the floods that happened in Durban recently. That flooding exposes humans because it brings us more into contact with polluted waters. It pollutes our water sources, which are rivers. For those who are in South Africa, you will understand that a large proportion of our population lives in informal settlements where they rely on these rivers. So they will be exposed to that. And these drugs, the drought, on the other side, droughts, when there is drought, the water bodies dry out, but the few water bodies that are left increases use from animals and humans, and these water bodies are more polluted because they concentrate superbugs. And if we look in terms of the air that we just mentioned, we now know about the serious winds we get, just like what is happening out there now. This wind allows these superbugs in the air to be carried in distances we cannot think about. There is a study that showed that depending on the wind speed and the direction, wind can carry superbugs up to 10 kilometers away from where they were generated. And we have many activities that generate these superbugs and put them in the air. We have our wastewater treatment plants, for example. We have manure application in our farms. We have the tilling of the soil. And these winds just raise those dust particles that contain the superbugs and carry them to different distances. And as I said, also with the urban heat increasing and more of these bugs becoming resistant. So why is it important for South Africa then, or for Africa? Because I'm talking about the air. I'm looking about the air. If we look at the top 10 causes of death in Africa in 2021, we are seeing that lower respiratory tract infection and at the fourth position, tuberculosis, which are all respiratory infections linked to air, those are the main killers. And now if those are the main killers, and we have these superbugs in the air, does it ring a bell? It therefore tells us that we have a big problem here, because there is a component of the environment which is not addressed, which is superbugs in the air. And yet the greatest killers in Africa are all respiratory, which means they are transmitted via air. If we come down to South Africa, it's the same story. Okay, apart from COVID up there, but if we look here on the section of males, we see that tuberculosis is highest. If we come on females, we still see tuberculosis among the top 10s. So this therefore raises a question. Are we doing enough in terms of research? Are we doing enough in terms of the funding that we are putting to fight these superbugs? Because we are addressing them where we can see them, and we are ignoring where we cannot see them, yet they are having an effect. I would like to leave us with this one slide from the World Health Organization that says that many people think that antimicrobial resistance is primarily caused by overuse of antimicrobial drugs, but the environment or environmental factors may cause the spread of AMR even more than the use of antimicrobial, especially in developing countries. Now, If we look at that, this is the WHO that published the recent GLASS report focusing entirely on humans, still saying here that the environment is doing more than what it can people can see, then it means there is a problem somewhere that is not addressed. Since this is a discussion, let me thank Bhekisisa, the University of KwaZulu-Natal, and the other organizations for some of the papers that I showed were generated from our labs. And thank you very much for your attention. I will appreciate questions.
Dr. King, we're going to get to more questions later, but I must say the picture that you've sketched is absolutely frightening. One of the questions we got in advance of the webinar is, what is South Africa doing? It definitely sounds like more needs to be done. Apart from, media attention, what are the policymakers in South Africa doing about this problem? This question came from Rosalia Whitehead at the SABC.
Oh, okay. South Africa is one of the African countries, I must commend the efforts, that has developed national action plans that includes superbugs. However, one thing that is lacking in that national action plan is that, as I said earlier, it focuses more on humans and animals, again, with heavy focus on humans. So the environment is dealt with less. And I think the last action plan expired in 2024. It needed to be updated, but the recent global financial crisis that led to the reduction in finances in many aspects also led to a halt in that domain. But I think South Africa is including superbugs in their national action plan. It's one of the top priorities of the country. It's just that it has been halted because due to finances. I'm not a financial expert, but I think it has been halted on that line. So I think South Africa is doing something within the continent.
Thanks, Dr. King. We're going to go now to Dr. Esmita Charani. She's with UCT at the Department of Infectious Diseases and HIV Medicine at Groote Schuur Hospital. She's going to talk to us. We're going to skip from superbugs being all around us to the air around us not being equal. The air we breathe is not equal. We'd love to hear from you, Dr. Charani. Thank you.
Thank you very much, Ida, and thank you to everyone who's attended to listen to our talks. And thank you so much to Dr. King for setting the scene so well for me, so I don't have to talk so much about the where we are with AMR and how we've got to where we are, but more about the inequalities in how we experience the threat of antibiotic resistance based on our identities, based on where we live, and socioeconomic conditions that determine our living environment, and how that in turn determines our exposure to antibiotic resistant pathogens and the consequences of that exposure. So I'm a pharmacist by background, but I've been doing research in antimicrobial resistance and antibiotic use in human populations for the last 15 years. And for the last 5 years, I've been working with South Africa and India specifically to look at how we are dealing with the problem of antibiotic resistance in different countries. And just to highlight what Dr. King talked about in terms of national action plans, these were developed originally by the World Health Organization, and then each country from a global action plan, and then each country developed their individual action plans. But within this set of sort of objectives or targets that countries have, we work in very, very different healthcare systems to deliver to the needs and to the objectives of these action plans. And I'm just going to illustrate this differences in resource capabilities that we have within and across countries. These are just examples of antibiotic prescription charts in use in hospitals currently in different parts of the world. This yellow chart at the top is from Amrita Hospital in India, where we work very closely with colleagues looking at the sociocultural determinants of antibiotic use in hospital settings. And, something as simple innovation as having a yellow border was able to identify to medical staff immediately if patients are on antibiotics, so that we could give them in a timely manner. In the bottom here is an institution I used to work at in the UK, in London, before I moved to South Africa, where we implemented electronic prescribing, and it had its own issues in terms of prescribing antibiotics. The chart in the middle is what we use here at Groote Schuur Hospital in the University of Cape Town, where researchers brought in all the elements of optimum antibiotic use to help us make our decisions more clearly around antibiotics. And then here we have in lack of a prescription chart, just from a hospital in Uganda, doctors are using exercise books to be able to draw up charts for patients who are hospitalized. And a lot of the people in the world, in different parts of the world, are sent home with their medicines in a plastic pouch. So I use this to illustrate the inequalities that exist and the inequities that exist within and across countries when it comes to resources we have available to make sure that we give antibiotics appropriately. And this inequality is perpetuated and replicated in many different ways, in access to medicines, in access to interventions to help us mitigate the threat of antibiotic resistance in different populations. And there is a whole host of interventions that we implement in hospital settings, in primary care, to be able to respond to the threat of antibiotic resistance. And we give an umbrella term to these set of interventions, and we call it antibiotic stewardship, which is all about the specific. For example, this chart in the middle is an example of antibiotic stewardship. We're trying to guide physicians to give the right antibiotics. But when we look at the differences in different income setting countries between high and low middle income countries, we have to think about what is going to give us the best return for investment in different settings. In many parts of the world, it is still about the living environment in which people live and access. So more people continue to die from lack of access to effective antibiotics than from overuse of antibiotics. And that's something that we need to bear in mind. A lot of the research indicates that in low and middle income countries, the interventions that are going to have the most impact is infection prevention, access to water, hygiene and sanitation, which we call WASH as an acronym, and providing high priority pediatric vaccines to prevent infections from spreading and emerging. And the populations at greatest risk of acquiring a multi-drug resistant or a resistant bacteria that is difficult to treat are the very young, the very old, the severely ill, and those in resource-constrained settings. And I'm going to talk a little bit more about resource-constrained settings because that is the focus of our work here. So through our collaboration in India and South Africa, we have been visiting lots of different parts of the country, in South Africa, in Eastern Cape, and in Cape Town, in Khayelitsha Township, but also in Groote Schuur Hospital, where we work, in India, across different states, from very socioeconomically deprived states to more affluent states between the north and south, having conversations and workshops with healthcare professionals and members of the community. And I'm going to use an example of a case study last year when we were incidentally on World Water Day. We went to the town of Baddi, which is, if I can, yes. So the town of Baddi is an industrial hub in Asia, one of the largest industrial hubs in Asia, where many pharmaceutical and cosmetic companies have sites and plants. And this town has a river Sistra that flows from the foot of the Himalayas right through, snaking its way through the city, past the plants, into where people live, including in informal settlements. A lot of these industries are primary, secondary, and tertiary industries. And primary industries have direct responsibility for ensuring that they do not release untreated effluent water into the waterways. Secondary and tertiary industry have different levels of regulation. And so often abuse happens when the primary industry, for example, if they're making antibiotics, they will rely on a secondary or tertiary pharma industry to produce the active ingredients. And those industries release their untreated effluent into the water systems, contaminating the water systems that people who are socioeconomically deprived are more likely to come into contact with. So we went for a day in the town of Baddi and we spoke to people who live in these communities. And we asked them, what is their relationship with the industry? A lot of the men are transient workers in the pharmaceutical industry that is there. A lot of the women are the ones that come into direct contact with the water in this river because of cleaning clothes, washing clothes, preparing food, feeding the animals. And actually the woman told us we are getting skin conditions and lots of complications, health complications from being in contact with the water. And then we asked them what happens with the climate, what happens when there is extreme weather, if there's a drought or there's flooding. And they said, well, when there's flooding, again, it's the women who have to pack up their settlements and move to higher water. When there's a drought, they don't have access to water to clean and to be able to carry on their daily practice of living. And you know, their livelihood is sustained by this river that is heavily contaminated. And they told us also a lot of their animals were dying and they couldn't understand why. Then we asked the women in the settlement, how do you access healthcare? And they told us, oh, the doctor comes to us. So what happens, we understood in this community, that a lot of young men wear a white coat, go to the pharmacies, and there are over 3,000 accredited and non-accredited pharmacies that are directly acquiring, sometimes from the black market, from informal routes, medicines that are produced in these pharma industries, in the city, and they sell it on to these young men, who then powder or compound it and sell it on to the community as medicines without understanding what it is that they're selling. And some of these are antibiotics. So in antibiotic stewardship, we focus a lot in secondary care, in hospital settings, not understanding or not paying attention to the many socioeconomic and environmental drivers of exposure to antibiotic resistance in the community. When we spoke with, through the workshop with colleagues in India, we had gender and caste activists. And what they told us, they brought in this term, which I found really fascinating, to describe the inequality in society, and they called it olfactory segregation. That depending on how close you live to sewage works or to a pharmaceutical plant, that tells you immediately the level of socioeconomic deprivation that you have. And that is also indicative of the risk of exposure to environmental contamination that you will experience, including from the effluent from these industries, which may be antibiotics through exposure to waste products and also through exposure to unclean water for everyday needs. And there are studies that have shown, for example, that are looking at antibiotic resistance in the environment, using selected aquatic environments to understand the different sources of antibiotic pollution. Pollution is highest in industrially polluted surface water, untreated hospital effluent, and untreated municipal sewage. And these are all much more likely to be in close proximity to people who are socioeconomically deprived, based on their many layered identities, whether it's by indigeneity, by migration status, by income level, by caste in India, for example, racial segregation. So for all of these reasons, the inequality in society is perpetuated, and it's something that we need to focus when we look at the environmental impact of antibiotic resistance. When I came back from the trip to Baddi, I actually went to the website of some of the pharmaceutical industries that I saw active in Baddi. It's very interesting when you look at how they project themselves to the world. They all pledge to have an environmental responsibility. So, for example, L'Oreal has a site in Baddi, and L'Oreal is a cosmetic industry, not a pharmaceutical industry, but just as out of interest. And they have put some potted plants outside their compounds to make it look pretty, but they have paid no attention to the actual environmental waste that is happening. But on their website, this is the picture they have. They do not have a picture of their plant in Baddi. They show a very different image to the world in terms of their corporate responsibility in relation to environmental safety and contamination. There are studies that have demonstrated that regardless of the country in which you are living, whether it's America, whether it's India, social determinants of health are directly linked to environmental disparities, and environmental regulation is variable, and industry abuses this. And in any country, in any setting that studies have been done, it has always been demonstrated that marginalized communities are subject to environmental segregation. And this is something that will have a knock-on impact on exposure to AMR pathogens, on lack of access to wash, but also on health outcomes. And this is something that we need to debate about: how do we ensure environmental and corporate responsibility with these big industries? And that is something that really has not been tackled enough. So we had these workshops and we followed on our conversation with further workshops with community activists in South Africa, working with AWOSA, that is a NPO funded by the Wellcome Trust, where they do active engagement with youth and adult learners about public health, but also in India, in Bangalore, with gender, caste activists and environmentalists. And we decided how, and including Dr. King, who was here for the South Africa Cape Town workshop, to discuss about the implications of this for AMR and how do we move forward to have a One Health approach that has environmental considerations in its core. And we use a case scenario of an outbreak in a township to illustrate the issues and the voices and concerns of different stakeholders in this debate. And this includes the patients and the public, NGOs, hospital administrators, regional government, and international organizations. And at every level, there are responsibilities that need to be taken into consideration when we develop policy and guidelines, when we develop expectations of how to respond to AMR, particularly around the influence of intersectional aspects of antibiotic resistance and how it impacts different communities and people with different socioeconomic and sociocultural determinants and drivers. For example, whether you are a migrant, whether for example, in India, if you come from different socioeconomic culture of society based on caste. In South Africa, race still is an important factor. In the UK, in Europe, it may be migration status that will determine living conditions and privileges that are associated with being, or lack of privileges associated with being a migrant rather than not being a migrant. So an intersectional lens is really important and brings in the environmental impact and links it to climate change and climate impact of AMR. In a changing climate, how we're going to address the issues that are rising in different populations, but also the balance between access, effective access to antibiotics when they are needed versus excess in antibiotic use, which may also contribute to antibiotic resistance. And this is two sides of the same coin, and it needs to be understood that it's not always about curbing excess use. It's also about allowing access to antibiotics and innovations to be able to manage the risk of antibiotic resistance in different settings. From an intersectional lens, it is also important to consider different identities of individuals, including gender, roles, and norms. And just in that snapshot example I gave from Baddi, just speaking to those women and men, we found, even through their lived experiences, the differences that people were telling us about inequality, environmental inequality, and how it impacts health. There are many studies to show that with rising temperatures, women's health, particularly maternal and infant mortality, is impacted severely. Rising temperatures have been linked to antibiotic use, and also increased compromise wash and wastewater management. So the work we are doing now is specifically trying to understand this from an intersectional lens. How does our positionality and fallback within society and the family, based on our gender roles and norms, on our religion, on culture, impacts our access to privileges such as education, occupation, and wealth? And how does that influence our access to resources, including to WASH, to vaccination programs, to healthcare, and how much of this is recognized in policy making? If you're interested in some of the work, I'm going to finish with this slide, which is, we work very closely with the WOZA, as I mentioned, and the youth that we work with develop documentaries based on the problems that we discuss with them, and they have developed 2 documentaries on public health and also on inequality and global health. And these are available on this website. And they have many other documentaries that are very interesting about public health issues and how inequality is impacting health in different communities. So I'm going to stop there and say thank you very much.
Thank you so much, Dr. Charani. It sounds quite overwhelming and obviously needs to be talked about and written about more. I want to go immediately to a question from Natasha Naidu, who posted in the chat box something that was also on my mind. How do you prove a causal relationship between these environmental determinants driving AMR and disease transmission itself? How can you prove that there's an actual cause?
Do you want me to go first? I'll go first.
Yes.
So, for example, we know there is ample evidence to link lack of access to water, hygiene, and sanitation with the emergence and spread of antimicrobial resistance. That is an environmental determinant that has been proven, and there are many studies around it. If you look at overcrowding in housing, and for example, TB, which is a specific drug-resistant infection, that has also been proven. But also the environment has other effects. If you are living in a compromised environment due to socioeconomic drivers, you are more likely to develop infections that may then become drug resistant, for example, skin and soft tissue infections. Women who give birth in unsanitary conditions are far greater risk of developing post-natal infections. In fact, and that includes in compromised low infection control facilities that are often linked to social determinants of health. In South Africa, if you have access to private healthcare, you will have a much better care provided to you than if you do not. A lot of people living in townships do not, all people living in townships do not have access to medical aid. They will receive a very different level of care. The resources are very limited. We see very resistant infections in our hospital here in Fortescue Hospital than we would see in a Netcare hospital. And that is linked to social determinants of health and environmental pressures and unsanitary conditions in which people live, but also in which they are treated due to resource limitations. I could go on and on. The other thing is, if you look at, so in South Africa, access to medicines is very regulated. Still, people can buy medicines in townships as and when they need and use antibiotics inappropriately. This happens a lot more in countries where the enforcement of regulation around access to antibiotics is different. I myself have bought for 20 rupees azithromycin in India when I had a chest infection, and I was there with infectious diseases colleagues. And I used that opportunity, even though I preach others not to do it. When it's available to you, your decision-making processing changes. And I did that in India. So if I did that, and I am an expert in this subject, how do other people manage to treat their own infections or their own illnesses when they do not have access to healthcare? And the easiest thing is to buy the 1 dose of antibiotic or 2 doses of antibiotic that you can afford. I hope that's answered your question, but I'm sure King can add to it.
If you have something to add, King?
No, you've just said everything already from that social perspective, but from a scientific or a micro point, the way I usually put it is, we've done studies, we have established studies that shows that the organisms or the superbugs that we isolated in humans were the same superbugs that we isolated in the environment. And there is proof that these people were interacting with that environment continuously, especially in informal settlements. So it's not by chance that they carry the same superbugs that's in the environment. And there is an epidemiological approach that we use to quantify that without necessarily going to test the people. There is what we call quantitative microbial risk assessment, where we say, let's say we see a river, for example, and we know that the community is using it. We test the river, we know what is inside the river, and then we see what the people are using the river for. And based on that, we can calculate the potential risk that involves in somebody with somebody getting an infection from there. So there is that evidence that shows that yes, the environment is directly linked to that, and that is why there is the whole concept of the WASH. That is water, sanitation, and hygiene, just as Esmita has said.
Thank you very much, Dr. King and Dr. Charani. What you both sketched is really quite overwhelming, quite scary. And as a journalist, I would almost not know where to start. And there's a question around that from Estelle, which I'd like you to address. And that is that there's a principle in journalism that we shouldn't give people information that with which they can't do anything. You know, it becomes overwhelming, it can become depressing, and therefore not useful. So what would you suggest ordinary people can do about this? How can also our stories as journalists be written in a way so that it doesn't feel overwhelming and it doesn't feel as if it's just sort of, you know, giving people depressing news and there's no way forward? What would you suggest?
Can I? Okay, you can.
Yes, and then Esmita, thank you.
All right.
Yeah.
Okay. You see, that is one of the biggest challenges that scientists from our end we have. We do these fascinating studies, we write wow papers that get published in Nature and everything, but how to take it to the community becomes a challenge. However, if there is, because we talked about the One Health, if there is that communication between the journalist and the scientist, then it's easier to write up the story. I'm going to give an example, for some work that I did sometime in Pretoria. I was working on a river and I found that there were superbugs in that river. The river was highly polluted and those people didn't have water in that area. But I didn't know how to write that to the common person or to the community. But I wrote a scientific paper. But then I was approached by a journalist, and that said, we saw your paper. They were reading some science papers. How do you think? Do you think we can work on this? So we wrote the story and brought it down to a community level. And when the story went out, I think 1 week after, Human Rights Watch was in that community to ensure that, to see what was happening. So we take, for example, these superbugs that we are saying. A lot of people don't even know what it is. And we are aware that there are people who go to the clinic and they want medication for a cold. If you tell them that, no, you are not going to give them antibiotics, it's quite a problem. They tell you it's their right. They have their right for medication. But if they can be told what it is, what that cold really is, and what shouldn't be used for antibiotics or these medications, then they will understand that when next they go to the hospital, they can tell the doctor, no, I'm not taking antibiotics for the cold that I have. You can't be giving me antibiotics, because we also have wrong prescription when people go to the hospital. Apart from people asking, we also have cases where the doctors themselves are prescribing. You are going to be surprised that it's not just in developing countries, because in the US, for example, more than 50 million doses of antibiotics are prescribed wrongly. They are not needed. So I think there should be that work between the scientists and the journalists to understand those things. And then, I mean, come to an understanding, just like you asked me, is it okay to call them superbugs? And I said, yeah, I think that's a good term. So if we communicate like that, then I'm sure it's possible to carry out that information to the community in a way that they will be able to use it. Thank you.
Thank you very much. I think you would agree, Dr. Charani. So I'm going to go to this question by Kirthana Anikumar. Is the presence of superbugs in the air easy to identify or to measure? And I wanted to say, when you spoke about superbugs in the clouds, I was just trying to imagine it. How do they even get there? How have they been measured? And what does it actually mean? But yeah, so you see the question by Kirthana. Would you please answer that one? Thank you. Who would like to go? Actually, it is a question for you, Dr. King.
I think so. I was going to say these questions are directly at King, not me.
Yes.
All right. Yeah, it's, you see, the thing is, aeromicrobiology, the way we call it, or atmospheric microbiology, is one of those aspects that are coming in new within the science field. So there are specific samplers. I spent 1 month in Canada last year to study how to sample the air. And while we are talking, I have in front of me a box and something which I could quickly show. Okay, it's hidden somewhere there. But I have in front of me an instrument that allows me to trap air, like to pull air and put it in water, then analyze that water to test for bugs. It's not a new technique. It's an old technique that has been used during wars to, for example, determine whether a country has used lethal gas or whatever, bioweapons or gas and everything. That's the same technique that is used to sample the air around to determine such. So we are simply bringing that technique now into microbiology to understand how these organisms are in the air. It's not very easy. For example, if we have to take a massive air sampler that can sample like 4,000 liters per minute or per hour, we are looking at about $13,000 for just that instrument. So you see that, with, as Esmita said, we don't breathe the same air. We don't also have the same funding. So it might be difficult for some countries to do such research. And within South Africa, I think there's only one study that I saw a long time ago that did one study on air. And yeah, but it's not easy, but it's doable because it's being done already. There's a way of trapping that air, converting the air, trapping the air into water, then using that water to analyze for the presence of those bugs.
Thank you, Dr. King. I can just imagine a TV feature being done with you and your box and, measuring something that we can't see, but coming up with evidence for something that can really translate into a story that's so important to tell. I'd like to go to the question by Sama. And it is a high science question, but I would love for you to answer it in a way, if you can see it, Dr. King, about whether we should or how can we promote the development of locally produced, low-cost antimicrobial alternatives, such as bacteriophages or green nanomaterials in Africa to combat AMR or antimicrobial resistance. Who would like to take that? Esmita, I see you nodding.
I need some backup from King here, but the issue about bacteriophages is when I was at university, long time ago, I won't say how long, but we were talking about bacteriophages, and we still are, but they've never been able to go into mainstream use for us in terms of responding to AMR. I think in Russia, there are some studies, and in Eastern European countries who are more interested in bacteriophage. But we have never taken that seriously enough in relation to how we incorporate it into treatment of infections in humans. The other issue around this, and I can't speak for Africa, I've been here for 5 years, which is equivalent to being here for 2 seconds, but generally a lot of the manufacturing and pharma is concentrated now in India and China. So, but the innovation for new drugs often is still driven by high-income countries. So what we do need to do is really invest in innovative new technologies and solutions to manage antibiotic resistance coming from this continent. So Scott Maftawali, who's based at the London School of Hygiene and Tropical Medicine, has written about this. He's written a blog about this opportunity for African countries to take on investing in more pharmaceutical development within the continent to manage the issue of access. I think that's a really important conversation that needs to be had, and investment that needs to be made. But I don't know enough about green nanomaterials. I have to say that is way out of my expertise. I can't comment on it. But King, I don't know if you want to add anything to that question.
Okay, thank you. So there is, I think in 2010, I attended this summits in Kenya, where there was this whole, it was organized by the World Health Organization, and there was this whole push about the African medicinal plants or African medicinal richness in fauna. First, if we start by looking at it, we'll realize that a lot of the drugs that we have out there, the medications that we have out there come from natural sources, right? The challenge we have within the continent is that we do not have resources enough to convert that into packageable material. And at times, when we even go up to the local point of producing, there is no quality control. For example, if you go to one of the markets, let's say in Eswatini or Malawi or somewhere, you will just see packages of things that are being sold in very deplorable conditions, for example. Now, you are already sick and you want to buy medication, and the medications are placed on the table that is not clean, So because of all those, it becomes a bit challenging. However, it doesn't stop African scientists to generate that data. For example, if we look at what happened with the COVID, it took less than 6 months for a vaccine to be generated with the age of AI. It's true that the capability is not that heavy in Africa yet, but using desktop studies, it's possible now to understand what is in what plant, what is in what organism, and how that interaction can occur. That experiment can be done now faster than it was done in previous years. So while it is still challenging, it is not impossible for the African scientists to still do that. They just have to go slowly. And again, I'm happy that superbugs have been made a political issue. It was declared a political issue just during the last UNGA. So it means that now African governments will have to set budgets aside to promote such studies so that African scientists can prove that this is what is happening. We have, like in KZN now, at UKZN, there is a team that is working on developing some treatment for HIV. And based on the last reports that we are getting, they are getting positive outcomes. So it's not impossible, it's difficult, but it's still there. So I think Africa has the potential to do that.
Thanks, Dr. King. You both spoke about, collaboration. Dr. King, you mentioned One Health, and there's a question from Romain Karan, which I'd like to put to, actually, I think both to you. And this is again about the causal link. Is it climate change as such that is causing the rise in these superbugs in general? But Romain's question is about whether that the same applies when there are those climate shocks that we can feel around us, a sudden, hurricane or floods that are climate shocks, those individual events. Can that be proven? And, in order to be able to answer that question, to what extent are climate scientists and AMR specialists working together to kind of, paint a full picture of how the two are linked?
I can start because I gave a talk on this at Esmita this year, and I was with a climate expert, and we actually discussed this German Watch report, which I really encourage you to look at, Romain. It's very nicely puts the data around extreme climate events, and it compares a 2-year challenge versus a 30-year challenge. And what it shows is over the last 30 years, there has been an incrementally increasing extreme climate events happening in many countries around the world, but the country that is experiencing it the most, actually 7 out of the 10 top countries are now high-income countries. But when you correct for the Human Development Index, the most burden is going to be felt in low and middle-income countries. And what it is showing in this report is that countries are not prepared for these increasing, recurring extreme events that are happening. And most of them are droughts, flooding, and heat waves. Those are the most common extreme events that we are witnessing globally. Now, each of these will have different health-related risks. There are now increasingly collaborations between climate experts and infectious diseases and AMR experts to see how these crises are intersecting to impact health of human populations. Using US data, One Health Trust India has demonstrated how for an increase in 1, I think, Fahrenheit degree temperature, not Celsius, there was a 5%, I may be wrong, but there was a significant percentage increase in antibiotic use. Now, we don't know why that is. We can hypothesize. But what we do see over time, it is changing shifts in human health. For women's health, it's definitely there is evidence to suggest increasing stillbirths and miscarriages with increasing temperatures. And that has implications for other health conditions. So some of it may be directly related to AMR, some of it is indirectly related to infections and AMR. But we do need to, I agree with you, Romain, we do need to work more closely together on this issue. But what is clear is that globally, we are not prepared for the increasing recurring extreme climate events that we are seeing. In the Valencia floods, the majority of the people who died were over 70. So we are not, our health, and that is a high-income country, but our health systems are not ready to deal with the burden on health that is being generated by these increasingly occurring climate events, extreme climate events.
Thank you so much for that, Esmita. And Dr. King, did you want to add something?
Yes, I would just want to put, I'll take 2 scenarios. The first one is the recent COVID. When the COVID hit, what I did is I went into world data to look at what was happening. And if we also look very well, the countries that were having the highest COVID records at that time were experiencing unusual cold weathers. Although it was their winter, but the cold was unusual compared to the previous time. So I tried to compare all those countries together with countries that had low counts. And there was a clear indication that those countries that had that sudden burst in cold had more of the cases than the ones that did not have. And this is because these bugs, first of all, cold would preserve bugs or whatever thing. In terms of flu, that it increases because it also affects the human body first, makes the human prone to infection because it lowers the immune level of the lungs. The same thing applies, for example, when we have a sudden flood. If we look at South Africa, the data for Southern Africa, I looked at that data from 1903 till 2016. When I looked at that data and tried to see what was happening between that time in terms of temperature, in terms of rainfall, and in terms of cholera, I realized that South Africa had its worst cholera outbreak in 2009. And that 2009 is that directly coincides with the highest rainfall South Africa has ever had between that period. So it's not just by chance that there was that peak. Just as I explained, the more there is rain, the more we have these sudden floods, the more we have exposure between humans and those places. Take informal settlements, for example. When there is flood, the water comes into your house, you will be exposed to it, whether you like it or not. Even if you are not in an informal settlement, you are in the cities, like we see the ones that happened in the US, for example, where the floods swept all over the place and people were in the street. But they come in contact with this. So there are studies that show, I think the World Health Organization even has a whole document on how to work during such moments, because the disease burden increases automatically when we have a sudden flood. So there is that direct link, and it's always there.
Thank you so much, Dr. King. I see many more questions in the chat, and there are also many more questions that we received. I'm taking the liberty to take one more from the chat and one more from our questions. And I know that we've run over time, but I think everyone's so fascinated. I'd really like to ask a question that Shepo Mokhadi had. What are the emerging trends for the spread of superbugs in low and middle income countries? Again, what you've said was so comprehensive and in a sense felt a bit overwhelming. What are the trends? What dots can you connect with it when talking about the emergence of superbugs in especially low and middle income countries? What are the standouts?
One phrase, it is increasing.
And inequality
Superbugs are increasing.
And inequality is causing this division, greater division in how we respond to it. I think it's very difficult. And actually, I really wanted to talk to the question about how we talk about this and the information, because we're living in an age of disinformation and vaccine skepticism. And so we have this perfect disaster scenario, nightmare of people rejecting proven solutions that will help us. And moving away from it, and with a world of increasing inequality and increasing lack of access, is going to be a perfect storm for new pandemics to emerge from this. And I really am interested, how do we combat the misinformation and disinformation that exists in the space in which we work? And I think that is adding to the problem that we have globally, if you look at vaccine skepticism alone.
Thank you so much for that, Dr. Charani. Thank you. I see you answered the question that Marlies had, Marlies Craig. So I think we'll leave that one at that. It seems the perfect way to end, because that's the role that journalists can play as well, of course, to combat misinformation and through connections with yourselves, tell the story. Start at one end and work your way through the story, I would say. I think the scientists have both agreed that their contact details can be included when we, am I right?
Yes.
When we think, great, wonderful. When we send out a recording to this discussion. So look out for those. I think you'll agree that'll be great people to connect with in future. We are going to end now, but before doing that, just thank you very much to all my colleagues, to everybody who formed a part of this. We're going to post in the chat the Bhekisisa climate and health page, which we also urge you to look at, because there are lots of stories in there that have already been told, and stories that can be followed up on with new data and with new interest. And thank you so much for your interest in this area. It just feels like, to me, it feels like we could just continue talking about this subject, because there are so many questions still, and so many more stories to be told. Thank you very much, everyone, for joining.
Thank you. Bye-bye.
Bye-bye.
Pleasure. Thank you so much.